Hi, everyone. Good evening. Welcome. Thanks for joining us. We're going to give a few moments for everyone to get logged on. So welcome everyone to Mental Health in the Black Community, Crucial Conversations. We're excited that you're able to join us this evening. I do want to take a few moments just to go over some housekeeping. Number one, we are streaming this live on our Bluff City Medical Society Facebook page, and we are recording this webinar. So just to let you guys know, if you want to share this for individuals who may not have had the opportunity to register, you can share it on Facebook, and then we'll also upload it to our YouTube and to our website after this meeting. So take a moment to like, share, start a watch party to bring people into this conversation. And then please use the Q&A feature on the Zoom to enter your questions, and we'll try to get to as many questions as possible. We do not have CME that is available for this event, but I think that it will still be very useful nonetheless. So I am your moderator. I'm Dr. LaTanya Washington. I'm the president of the Bluff City Medical Society. I'm board certified in internal medicine and pediatrics, and I'm currently the vice president and chief medical officer of Methodist North Hospital. I'm very excited to be here with you today, and even more excited to have our guest panelist. I do want to invite you all to kind of take a look at our website. We're at bluffcitymedicalsociety.org, and also to follow us on social media. We are on Facebook, Instagram, and Twitter at Bluff City Med. I wanted to take a little bit of time to highlight some of the projects that we're doing with the Bluff City Medical Society. Our organization is an organization of physicians of color here in the Memphis metropolitan area. And we have a lot of targets. One of our main targets is really increasing the medical workforce diversity. And to do so, we have developed formalized mentorship programs within the Bluff City Medical Society. We have Project STAR, which is student achievement and retention, and Project RES, which is resident empowerment zone. So these are formalized mentorship programs for our medical students and residents. They are paired one-on-one with mentors who are in the Bluff City Medical Society that they get to meet with on a regular basis. And then we also understand that there are some things that we don't always learn in the classroom or in a school setting, such as study skills, professionalism, racism and bias, mental health and well-being, and financial literacy. So we support them through those modules as well. And then at the Bluff City Medical Society, we are having a member and mentorship networking event that will be on this Thursday, March 24th from 5 to 8 p.m. So for all of our Bluff City Medical Society members, students, and residents, make sure to check your emails to be able to find out where and when and everything about that event. We're really excited to be having an in-person event because there has been some time since we've gotten together in person. We are taking advantage of the lower COVID-19 case rates in our area to really get in some time to meet and greet everyone. One additional program that we are having at the Bluff City Medical Society, again, with a focus on increasing the medical workforce diversity, is our medical school recruitment fair. We are hosting this fair on the campus of Tougaloo College. It's going to be on April 2nd From 9 a.m. to 1 p.m., we have medical schools that are coming to engage with college students. Not only Tougaloo students, but other students are invited to attend as well, with the goal of giving these students really a roadmap so that they will be able to be successful as they continue on their search into medical school. So as you can see, we have a lot going on with Bluff City Medical Society. So in addition to our day-to-day work, if you are interested in participating in that medical school recruitment fair, you can scan that QR code to register for the event, and we will be excited to see you on April 2nd. So that's what all is happening with Bluff City Medical Society. Now we're going to get into this conversation, mental health in the Black community. I have to take the time to introduce our panelists this evening because I'm so excited. So first is Dr. Altha Stewart. She is the Senior Associate Dean for Community Engagement and Director of Public and Community Psychiatry at the University of Tennessee Health Science Center. She leads the department's efforts to create a community psychiatry program to expand the local behavioral health workforce. She's a graduate of Temple University Medical School and completed her residency at Drexel University. She's led large public mental health systems in Pennsylvania, New York, and Michigan, and serves on numerous mental health boards. At the end of May 2022, she begins her term as president of the American Association of Community Psychiatry, and she's past president of the American Psychiatric Association, Black Psychiatrists of America, and the Association of Women Psychiatrists. So that is Dr. Altha Stewart. Next, we have Dr. Patrice Harris. Dr. Harris is board certified in psychiatry and has diverse experience as a practicing physician, a public health director, and a patient advocate. In 2019, Dr. Harris was elected as the 174th president of the American Medical Association and was the first African-American woman to hold that position. Upon completing her term as president of the American Medical Association, Dr. Harris has continued in private practice. She regularly consults with public and private organizations on health service delivery and emerging trends in health policy. She is a visiting professor at Columbia University, an adjunct professor of psychiatry and behavioral services at Emory University School of Medicine, and an adjunct clinical assistant professor in psychiatry and behavioral sciences at Morehouse School of Medicine. She is also a fellow of the American Psychiatric Association. And that's Dr. Patrice Harris. And then our next panelist is Dr. Ron Bailey. Dr. Bailey currently serves as chairman at LSU Health Sciences Center in the Department of Psychiatry and is the Assistant Dean for Community Engagement. Dr. Bailey's career has centered on quality clinical patient care, forensic medical legal evaluation, advocacy, and community outreach. He has held leadership roles in academic, organizational, and professional settings. Early in his career, he served as the unit director of a schizophrenia treatment and research unit at LSU in New Orleans. He's also served at University of Texas at Houston and has had numerous accolades. He served as the 113th president of the National Medical Association from 2012 to 2013. He's also served as chairman of psychiatry at Meharry Medical College, chairman of psychiatry at Wake Forest University School of Medicine, and since January 2019 has been a voting member of the American Psychiatric Association Board of Trustees. So as you can see, this panel is highly accomplished. We are so excited to have them all here with us this evening. I'm having some technical difficulties. There we go. We'll stop the screen share. So welcome. Welcome everyone. Hi, Dr. Bailey. Hi, Dr. Harris. Hi, Dr. Stewart. How are you all doing this evening?
Doing well. How are you?
Good.
I seem to have some trouble starting my video. It says the host has to start it.
Oh, I have to start it. Let's see.
Okay,
Take
now
care of
you've
that.
asked me to start. Okay, gotcha.
There we go.
Hello.
Hello. I have to get you guys on camera.
Hello. I had the same problem. Oh, good.
Hello, friends. How are you?
Wonderful, friend. How are you?
Pretty good, pretty good. Back together again. The
Back
three
together
of us.
again, right?
Yes, yes. So excited to have you all here just because this is such an important topic. You know, mental health in the Black community is something that we have not historically talked about very much, but it's something that is really, really important. I think you all had an opportunity to see that quick screen share where it had the photos of two prominent individuals who had just lost their lives to suicide recently. It's Ian Alexander, who's Regina King's son, and then also Miss Chelsea Christ, who was Miss USA 2019. And I think that our community really felt like those were such great losses in our community. And it seems like now is the time that we really need to start talking about it a little bit more. And so let's kind of dive in to this conversation. I did want to take a little bit of time to talk about mental health, but I wanted to start the conversation really talking about trauma. And I feel like sometimes that's not always brought out when we talk about mental health, and particularly in the Black community, because what we have experienced, I would say over the past 2 to 3 years has really been a lot of trauma. I think about so many things. You know, I think the George Floyd murder was kind of the initial thing. And then we've had to deal with the pandemic. And then we all saw just the insurrection. All of those things were extremely, extremely traumatic. And so if I could get each of you to just talk a little bit about trauma and the importance of trauma as we are addressing mental health. Whoever would like to go first.
Well, I feel like I should let our guest go first since I'm a hometown girl, so please.
Well, I'll start. And again, thank you for this opportunity to continue this conversation. And it's always great to be with my two colleagues, Dr. Stewart and Dr. Bailey. And I think it's so important that you highlight trauma. In my inaugural address in 2019, I talked about the importance of elevating an awareness around trauma and talking about it, right? I know tonight we will talk about stigma and we'll talk about so many issues, and there's so much misinformation swirling around everything, around COVID, around vaccines, not new, a lot of misinformation about mental health. And so it's important that we talk about it. And trauma is something that I agree we have not talked about in our community for lots of reasons. I'd love to hear what Dr. Stewart and Bailey think about this, but I think in some ways we are such a nose to the grindstone, head down, got to get the work done. Sometimes not okay to share burdens, but sometimes just don't have the time or the luxury, right? If we think about it, sometimes people think it's a privilege to share their burdens, that we want to change that conversation. And we don't want to talk about maybe some things that happen within our families, right? What will it mean within our families? And there's shame. So many issues. So yes, trauma is critical. We have to think about trauma broadly. Those in the audience, some may be aware of a study that showed that children who were exposed to various episodes of trauma will that be witnessing violence, living in a home where there's intimate partner violence, violence in the community. There's increase in not only mental disorders, but it affects how our heart works, cardiovascular disease, diabetes. So we have to talk about trauma, but we can't just talk about it. We all, and I'm a big proponent of this, have to advocate for solutions and make sure there's resources for those who have been traumatized in our community.
Well, if you're going to let the guests go first, I'll jump in. Otherwise, I'll let you go first. I would also thank Dr. Washington for having us. I think this program went very well. Almost a year ago, we were on, and very happy to be back as well with my two very good friends and colleagues. I kind of came on tonight with kind of a set agenda to talk a bit about gun violence. I've been in New Orleans now for 9 months in the role that Dr. Washington mentions. I think I just moved here in June last time because Patrice made the comment that I think she wasn't sure I wasn't where I just moved. And I've just been flabbergasted, although I've been a violence researcher my whole career, at just the sheer qualitative, the nature, and how close it seems to you if you live here in New Orleans, the issue of violence. And I mean violence that's close to faculty at our university, people kind of driving out of the parking lot in the afternoon or going home from work. So these issues regarding, I think, violence are astronomically important. They unfortunately disproportionately affect persons who are marginalized and lack resources and many other ways to address the psychological and emotional struggles and difficulties that can occur in all of our lives. In some settings, some communities have been really recalcitrant in finding ways to address it, I think systemically, with key issues of healthcare and education and many of the basic so-called social determinants that are key, I think, in all aspects of life. I'd also say that I think the gun violence issue is so problematic in a particular community because there's an adverse financial component. The reality is too many groups or individuals benefit fiscally because there are so many guns and people buy them and they sell them on all kind of markets, and the fiscal value is so high. You can buy them in one state for a low price and some in a different state for a higher price. That until we, I think, as a community and a society, see this as, I think, the public health problem that it clearly is, and that I think the AMA said it was in 2016, and the APA probably a decade before. So we're going to continue to have these struggles, and I think, unfortunately, they continue to adversely affect our African American community. Issues that African American doctors should be very mindful of, and I think all of us, not just African American psychiatrists and psychologists, should be particularly attentive to and trying to find strategies and ways to modify and decrease these risks.
Well, and I did want our guests to go first. We're all Southerners, so that whole hospitality thing really works here in Memphis. And I want to thank the Bluff City Medical Society and you, Dr. Washington, for asking us to do this again, because I think the timing is absolutely right to have this conversation again and to take it up another level, kind of kick it up in New Orleans terms, Ron, kind of kick it up. Because right here, right now, the members of the Bluff City Medical Society are aware that every day on the news, we see another incidence of violence in this community, gun violence particularly, but also other forms of violence. And, we are trying our best here, as I'm sure you are in your respective areas, to get the attention that this needs and the trauma associated with that. Kind of violence, whether it's the psychological impact of this violence on child development, on community and family relationships, on however those things happen, and the physical consequences of this kind of violence. We have, at the university, we have just started a collaborative program with Labana around the kids who are victims of gun violence, many of them accidental shootings, but not all. Who are coming into the ER, the trauma ER, with these horrible injuries and not having adequate access to the resources to deal with them. So we're actually starting an intervention program in support of the trauma team's work to begin addressing some of that stuff. While the trauma team works with them in the hospital, we connect with them before they go home. We follow up when they're back in the community. We offer the kinds of supports that people may know they need, but don't know how to access. On the child side, we're doing that. On the adult side, when it comes to the consequences and lifelong impact of adverse childhood experiences and domestic violence and other things, there are some clear solutions to some aspects of these issues that we can and should be leading the way in. Bluff City is a very vibrant, active organization. with a lot of things that we can do as a group here in town. And so I'm going to take advantage of having this captive audience that you brought us, Dr. Washington, to explore mental health, trauma, and all of these things, and what we can do, how we can contribute to the solution. I took the liberty of inviting some people that I see have joined from across the country who are also interested in this, members of the Black Psychiatrists of America, who I know have a particular interest in this. Some local members of these organizations are also here. And, you know, I appreciate our medical colleagues, primary care, OBGYN, surgery, who are all happy to hear this stuff. And now we need to help them, colleagues, figure out what role they can play in helping to either prevent or intervene early on in some of these things. So that's my response to what's the impact of trauma.
Thank you so much. Yeah, you know, someone introduced that concept of trauma to me, and I thought it was so intriguing, and I thought it was a really good kind of building block for our conversation here tonight, and just understanding that when we talk about trauma, it can be something very small that is traumatic, or it can be something very large. You know, we often think about, you know, injuries, killings and things like that, but it could be other things. It could be something as traumatic as for the child that one of their parents is incarcerated or something like that, or they may not have access to food. Another thing that I personally find extremely traumatic is the way that on our media outlets is really portrayed, that they show repeatedly when our people are being killed, if there are videos of them. And I feel like there are times when they show those videos over and over again, and in a sense, people become desensitized to it. So much so that when we talk about trauma, particularly as it relates to Black people, that it lessens it in a way. Can you guys make a comment on that at all?
Well, I will just start off by saying that I think not only does it sort of normalize it in some aspects for people because they get used to seeing it, it also imprints on the young person or the person viewing it a sense of, this is all that I am. You know, you call a child juvenile enough and they begin to embed that in their spirit and begin perhaps to behave that way. We can do better. Words matter, and pictures and images matter as well.
I'll just say, you know, that was really brought home to me at 9/11. Of course, we know how often we saw the planes hit the World Trade Centers. And for us, or for many adults, they knew that it was, you know, a repeat of something that happened. But I remember a couple of kids I was seeing, or the parents were saying, that their young children thought that the planes were continuing to crash into the World Trade Center because they kept seeing it over and over again. So I have always worried, and I like that you raised the concern about the media on so many levels, how the media contributes to trauma. You're right, in some ways, some folks are re-experiencing trauma. In other ways, we get numb. There's a potential to get numb to some of these issues. And so it's critical that we call attention to how the media is thinking about and portraying some of these issues, and how they perhaps treat, you know, we've all seen the perp walk, and how different people from different races are treated. This was traumatic to all of us, but I think all of us have seen or saw how Black men particularly are treated when they are arrested. And we also saw the difference in the man, I'm blanking on his name, probably a repressed memory, who shot the folks at Mother Emanuel Church. And I will have to say that's particularly personal to me because I knew one of the women. So, you know, trauma and the media, critical, and we have to call that out when we see it. And We also have to, in some ways, remember self-care and care of those family members. The media will continue to show some of these things. And so that's when we have to remember that we have to turn some of that off. And that when we get up in the morning, we go straight to our phones. I'm guilty of that. And sometimes we get in the habit of doing what people call doom scrolling. So again, we have to be mindful of all of that, and with particular attention to how the media is impacting us and intersecting with trauma on so many levels.
Yeah, both my colleagues are right on target as always. There's so much to say, I think, in the space, Dr. Washington. I'll say three things. First, this stuff starts early and it's passed on along generational lines and institutional lines. I was sharing literally a longer story. I'll be short tonight about a sitting. I had a car wreck when I was in college. I had 5 or 6 people in the car with me. We had a pre-med program, and one guy was openly Caucasian or white, and others may have been, a mixed background. There were probably 2 guys there who were, dark-skinned African like myself. The police come, not really much attention to whether we're safe or not in XYZ. And they pulled essentially the white guy off to the side. We're all essentially 19 years old or what have you, to kind of get the story from him, whether we were telling the truth or not, or had been drinking, or the case maybe I was actually driving my father's car. It clearly, as Patrice says, leaves a lasting imprint in your mind that you are less than. Maybe after said it, you are less than, or even when there's a record, we're all there. The first issue, of course, is to separate us and overvalue one based strictly on issues regarding race. I'd also argue that I think the issue of trauma starts early, in that I think so many persons who are victims of trauma misplace, I think, the qualitative nature, as I mentioned earlier. I'll share another story. I asked my forensic scholarship about training. I had a case early in my career. I tell this story a fair amount, where I make a long story short, I saw a young man, actually a colleague saw him with me, and the guy had been shot in a bad event, if you will. It was a young, early 20s African American. Amongst a lot of things we talked about, at some point he actually stated, to get right to the point, that he did, hey doc, I didn't really know it would hurt to get shot. So this idea that I think violence is made not real, perhaps by the media, what I call the Bugs Bunny philosophy of violence. And then I think because there's so much of it in some communities, many people know someone who's been shot and kind of lived through it. And it almost seems to be less than the ethereally mortal over type activity that most of the rest of us kind of think about. You do everything you can not to be involved in that type setting. All issues, I think, have tremendous input on this issue, that if you live in a trauma-based, a trauma-oriented, a high trauma society, it has absolutely adverse psychological impact on an individual. And I think over time on a society and the community as well, huge issues that I think groups like ours should be mindful of and constantly attentive to, trying to not allow that to become the norm going forward.
Yeah. I would just add one thing. It struck me as we were talking that as a group of doctors, one of the values I think in these conversations is that we as psychiatrists get to share with our medical colleagues who may not be as familiar or comfortable with some of these, how do you do these things, that we've got to get better at helping people understand how to ask about trauma. Because if you just say to somebody, you experiencing trauma, the likely answer is no, I just, I have a day and I get through it. And so we've got to look at the signs that indicate there is very likely trauma, where someone lives, what kind of work they do, what are they exposed to in the course of the day. If they're coming in for a checkup or an office visit, are there other signs that we can be aware of that should cause us to want to ask additional questions about the individual's life, about their home, about the constant composition of who's there, the usual stuff, bruises and breaks and all of that stuff we're used to. Some of the more subtle psychological traumas may not be as obvious, and we can be helpful with that in terms of helping people to look for those things and how to ask about them as well.
Absolutely. That is so true. I know that we have several of our primary care colleagues on the line tonight. And so I think that is a topic that really deserves a bit more discussion, because I see so many primary care providers that, they may be able to care for individuals that have very mild cases of depression, but then when we get into those more severe cases, then they don't really know where to turn. They don't necessarily know what medications to prescribe or how to get their patients referred into therapy and counseling services. And so I know that each of you all on the line here are experts at that. So kind of give them just a quick way to help navigate that situation, please.
I was going to jump in. In fact, I think I already mentioned it, but this scale, this early life with adverse childhood experiences is becoming so popular increasingly now in settings that where I am. In fact, I'll share with this group. We're actually trying to LSU Psychiatry now to get access to provide clinical care in the local jail, the Orleans Parish Prison. 1,000 persons there, over half on active psychiatric medication, and I would imagine more than that with pretty substantially adverse, early childhood experiences that very often just kind of leads to emotional difficulty that carries on and on and on intergenerationally. One of your questions here is about intergenerational trauma, and I've just been, again, speaking about the New Orleans experience, just surprised how often persons speak so fluently and so easily about how difficult the trauma can be and how rampant they've been throughout. I don't just mean when we think a couple of generations, I mean generations 5 or 6 or 7 generations deep in some settings, grandfathers, so to speak. So there certainly are, I think, some rating scales can be beneficial, and the cutoff number, I think 6 out of 10 is the number on the ACEs that we look at. But it's been very helpful, I think, to at least break the ice, so to speak, and encourage us to be thinking about what happened in the past and what probably may lead in an ongoing trauma for a person we're seeing today.
I think the integration of mental health care into overall primary care is critical. And Alpha said something that was so important. We can't just talk about it, right? And I'm glad to see all of my colleagues on or see virtually tonight. But what I think is necessary is, and I remember saying this several years ago, and so I'm going to start saying it again, and you're doing it tonight virtually, but I think we should commit to at least once a year, but maybe twice a year, having a day-long symposium, seminar, educational session about the nuts and bolts of how we help our primary care colleagues do this. There's one model out there, right, that we know has evidence. That's the collaborative care model. I think we need to, and I'll just say all the psychiatrists on the call tonight, we need to make sure that we are giving our primary care colleagues the tools and resources that they need. And so I think going forward, and thank you for having this conversation tonight, but once a year, and hopefully we'll all be meeting in person, perhaps there could be a bi-directional training, again, maybe not the same day, but psychiatry and mental health one-on-one for our primary care colleagues. And I will have to tell you that I also wanted maybe I don't know what you would call it, primary care one-on-one
for a psychiatrist, yeah.
Because when I was the medical director for the ACT team, and that's a team that takes care of those who have schizophrenia and bipolar and need intensive level of services, they would come to the office with blood pressures of 180 over 160. Now, I could default to sending them, I live in Atlanta, I could default to sending them to Grady, and they wouldn't go, right, for many reasons. Sometimes these folks were actively psychotic, perhaps some delusional. And so I really needed to know, and I would have to give my primary care colleagues blessing, is there something I could start, right? If I see that, what can I start, right then and there before I try to get them into care? Because if they went to Grady or any, they probably wait 8 hours, right? And so that was, and then they probably leave. So I think that we should all commit to doing this at least once a year with those bi-directional learnings to help one another out. We should give tools. And then many of you know that I spent a lot of my time in advocacy and policy. And I remember talking to a couple of primary care colleagues on the AMA board, and I said, you've got to do medications for addiction treatment in your office. We need you. It's not enough. And one of my primary care colleagues said, Patrice, sometimes it's not that we don't want to, and I say this a lot, but they said, what else do you want me to fit into my 15 minutes with all the other things that I have to. And I think we should, so that's why we advocate for better reimbursement and maybe value-based care when it makes sense for the patient to be able to do some of these things. And that's where maybe team-based care. So maybe the doctor is not, but there's somebody else on the team in the office doing that piece, asking some of those questions that are non-medical related. So I will just say my suggestion is, because again, we can say tonight, but we just have a limited time. We need to operationalize some of these training opportunities and give our primary care colleagues support and nuts and bolts of how to do this.
I 100% agree. And a few years back, there used to be an annual conference here that was sponsored by UT's Department of Psychiatry and Family Medicine, which was in part devoted to the psychiatrists understanding more of the primary care issue and the primary care folks understanding more of the psychiatry treatment. And that sort of fell out of existence. And certainly Bluff City has a strong enough relationship. I can't speak for the nation, but Bluff City has a strong enough relationship with the university and the university leadership to propose that that be resumed with UT support and allow local doctors to participate for some, if there has to be a cost related to the CME portion or something, that there be that kind of educational activity available to keep us all current in our respective areas and to help us figure out ways to collaborate more. Our workforce development will benefit from that level of collaboration ultimately. And I'm this year, I'm all about workforce development because we got to train some more psychiatrists. We got to get a more diverse and larger workforce out there. You guys are calling me about where is the psychiatrist to see my patient. I want to get some trained real fast so I can get off the hook.
I've actually attended that conference before.
Or we can recruit some more. I'm open to recruiting people. Ron, if you know some people, or Patrice.
Well, we would tell you the match here and got our fingers crossed. Had some success, not as much as we would like. I think these are good programs. As well as both of you, thank Dr. Walsh for having it. I'm hoping that there can be some young people across the country that are here. We're openly recruiting, and I want them to come to you. So that's a start. I attended that conference in the past year. You're right, it was excellent. I thought that this theme of ensuring that persons went to hear individuals from a different discipline speak particularly to them, psych to primary care and vice versa, was a good theme. And probably one that I think we'd be smart to continue. And if Bluff City picks it up, they'd be wise. That'd be good.
I'll just say one more thing about this, and I'm sure present company accepted, but I think that we have to make sure that all of us are aware of our own biases and again, and discriminatory attitudes towards psychiatry and mental health. I think probably everyone tonight on this call is interested, right? Because you saw that 3 psychiatrists. So that's why I said present company accepted, but let's be honest. And you guys know, my other 2 panelists know that, speak the truth here. Although I think it's better, but I would say when I first told some of my attendings that I was going into psychiatry, they were like, oh my gosh, what a waste of a medical degree. And so again, fortunately, we've progressed. And everyone, I believe, for the most part, believes, well, I won't say everyone, but people are more and more attuned to the fact that, again, there is no health without mental health that impacts your ability to recover from cardiothoracic surgery or from a lot of other things. And so fortunately, that is changing, but there still that stigma exists, not only towards patients, but also towards psychiatry. But again, I think that's changing. But I will say one thing that I've heard from folks who are not well informed when I've encouraged some primary care colleagues to think about treating opioid addiction in their offices with buprenorphine, I've heard this, well, I don't have those patients in my practice. And I think, we'd always say, yeah, you may not have asked about it or identified them, but those patients are in your practice.
Those patients are everywhere. Yeah.
That is
Yeah.
so true. That is very true. It sounds like you guys are giving me another thing to add to my to-do list with having this kind of psychiatry primary care type conference. So I'll put that on the list and we'll work on it.
You are not you don't have to do this
Oh, I know
alone.
I'm not by myself.
You have
Oh, I
all of
know.
these folks on this call
Yeah.
who are part of Bluff City who want this information. And I know people like Dr. Shepherd and others are going to be right there promoting this with you.
Absolutely. I know that there will be lots of assistance to do this, and I think it's very much needed. Dr. Bailey touched on it, and Dr. Harris touched on bias a little bit. So I do want to shift the conversation and talk about the bias that exists within our communities, within our cultures, and how that might affect mental health diagnoses and getting appropriate care for mental health conditions.
Oh God,
Appreciate
all of us have war stories about this one.
I'm sure.
Go ahead.
I'll say a couple things. I'm very excited about this contract we're going after. As you guys can tell, we talk about it all night. But on the first part, I think you're right. Patrice made the point that very often the bias starts it's ubiquitous. It starts at the top. When doctors within the House of Medicine are biased because other doctors, it's a hugely adverse problem, and it sends a signal to other people that they can be biased as well. And it has a long tail to it. Not only is biasing, jocular and a bit, perfunctory and juvenile and adolescent, but it also decreases funding. You can't get your grants funded, and you can't get enough funding for hospitalization and for care of people who actually have, I think, functional difficulties or problems. And I'll squeeze this point out again. We're actually going after this. It's been a lot of my life on this lately. This grant provide care at the Orleans Parish Jail or Prison. And it's really brought out, I think, of an interesting degree of bedfellows. I mean, persons who are finally having acknowledged there's a tie between how bad we treat people on the front end, poor resources, lack of services, inferior access to care. And then there's some difficulty. It's not, in somebody's neighborhood. I mean, the violence is real and it's close in schools and in neighborhoods and in malls and on evening news every day. Somebody did a carjack, if the case may be. And then now some people end up going to a jail setting. That's the opportune time to provide some resources for intervention. So now they're looking at a 9-figure contract for healthcare there, whereas in the past it was an area that has been traditionally, underserved, underrepresented, and underfunded. So clearly, as the word gets out, so to speak, that these issues are linked and tied, and you really can't kind of run away from it. It's just that you can't arrest your way out of a violence problem or a crime problem. You certainly can't ignore your way out of a mental health type problem. And I hope that society appreciates that and that there's some continuity to it, I think, over time. You had a comment about George Floyd earlier, and I do think that some of this occurred because there are just many more discussions, I think, in a very pragmatic and very functional way in all communities after the unfortunate, murder of George Floyd. Hopefully that will continue to push us to do better and talk about these issues and drive into what I think better interventional strategies.
Yeah, I'll just, and because Alpha's a great historian, so I do want her to have the last word on this, but I'll start with George Floyd and the fact that police violence against people from communities of color, particularly Black men, not new, but it was just in the pandemic. We didn't have our usual distractions. Probably most people on this call, again, not new, but the rest of the world, it was apparently new to so many, and that's because without the usual distractions, that they couldn't look away. That is my analysis of one of the many reasons that received elevated attention. And we all know this COVID pandemic has just uncovered so many things: the lack of a public health infrastructure, the lack of a mental health infrastructure, not new, again, racial injustice. And we've seen the disproportionate impact on communities of color for a lot of reasons. Yes, comorbid disorders, but because communities of color were the frontline workers who didn't have the privilege of staying at home. And so bias, discrimination, racism, microaggressions, not new terms to many, but have been elevated in this pandemic. And no question, they're certainly impacted even diagnosis. And I'll just tell 2 stories, and then Dr. Stewart really can talk about this from psychiatry in general, but the House of Medicine, past president of the AMA, not without our faults. I think it's well known that the history of the AMA, and 50 years ago, the Black doctors in this room could not have even joined the AMA. Now, the good news is the AMA, like other organizations, there's been some progress, but we are still on our journey. By the way, just a quick story again about the AMA. Nathan Davis, I think, was an early president and really was one of the proponents of African-American physicians not joining. And we retired his name from awards. We used to give community service awards to government officials, very important awards, distinguished awards, but we will continue to give those awards, but not in the name of Nathan Davis. And the bust of Nathan Davis used to sit outside the boardroom in our headquarters, and that's retired. So again, it's about making the progress, addressing your wrongs, saying you were wrong, some healing and reconciliation, which again, we're not here to talk about AMA tonight, but the process of doing that. But all of these issues. So I'll tell two stories. And I was with the chair who was chair of the Department of Psychiatry when I trained at Emory, and I remember him saying something to me and to all of us residents. He said, every African-American young male that comes in to our emergency department is bipolar disorder until proven otherwise. Why did he say that? Because it was such a knee-jerk reaction to diagnose young Black men with schizophrenia. Right. And then all that comes with that diagnosis, which is probably more difficult to treat, less optimistic for the future. Although with our medicines, we are able to treat everyone and certainly improve no matter what your diagnosis. But those are some issues. And then on children, we found that children in school, particularly boys, are often labeled as behavior problems and not even given the evaluation to see if there is either ADHD or most likely post-traumatic stress disorder. We were talking about trauma earlier. So that to say you cannot get away in medicine and psychiatry without talking about these issues. Fortunately, this is the silver lining of COVID, for some, not all. We are talking more about these issues.
Well, my colleagues have really covered the waterfront in terms of the response. I guess what I can add is the more we talk about the psychological distress that has been expressed during this pandemic, during COVID's arrival and continued presence in our lives, the more we are understanding that it is not just the problem of people with a mental health diagnosis. The diagnosis itself is no longer the trigger for many people to have these conversations. It is that, quote, normal person before COVID who is now anxious, depressed, having sleep challenges, afraid of being around others, limiting their socialization, not finding joy in their lives, not wanting to be around people, that it is the dissemination into the larger community that previously did not consider itself in need of mental health treatment that has brought us to this point where we can have these conversations, because now it is not always just seen as a stain of deficiency and differentness. It is a normal response to a very abnormal experience that allows us to start the conversation. If we can but move this normal conversation into the realm of, and there are people within our society who have diagnosable mental illness, who also should not be shunned, who shouldn't be marginalized, who should be acknowledged for having medical problems that have medical solutions. Our rate of treatment, effective treatment of depression, rivals most cardiovascular disease, but we don't talk about that in medicine. We understand that many of the chronic conditions being treated by our primary care colleagues have a traveling companion in the form of depression, anxiety, and a multitude of other mental health issues. But we don't talk about that. And we can't continue to bifurcate in the aftermath of COVID, at least. I hope we will not continue to bifurcate the psychological disorder from the physical medical condition disorder. If we can but achieve that over the course of this post-pandemic period that we all hope we're entering, then we will have successfully managed to learn something from this devastating experience we've gone through.
That is so true, Dr. Stewart. There's so much more medical conditions during the pandemic, and then also the mental health conditions. And I think that another thing that COVID has exposed for us is just the workforce and the challenges that we have in workforce. When we talk about mental health professionals, there's a shortage overall, but then when we talk about mental health professionals of color, I think there's only 2% of all mental health professionals in this country are Black. How do we really rectify that, especially if people are wanting kind of culturally competent care?
That workforce issue is really a challenge, and the three of us have some level of experience, I think, in recruitment, in retention, and just in the encouragement of people to even consider it. As Patrice pointed out earlier, I was told I could be a real doctor. Why was I becoming a psychiatrist? Now, having gone through 4 years of medical school alongside people who ultimately went on to be vascular surgeons and cardiothoracic surgeons and plastic surgeons, just to name a few surgical subspecialties, I always felt that was a slap in the face. And actually, it made me want to be a psychiatrist even more, just to prove that good doctors came in all specialties. But the workforce issue is one that we have got to tackle early on. We had a speaker at Bluff City a few months ago who talked about it's not a pipeline issue, it's a pathway issue. And we got to get started much earlier, getting young people who are interested early on before someone turns them off. We've got to, as Ron said, we've got to convince our colleagues in the rest of the House of Medicine to not disparage and demean, even if they think it's a cute little joke, the work that we do, and the fact that when they need us, we can be helpful. Now, granted, we will all three admit that sometimes we are not the easiest people to get information from about our shared patient, but we are working on that. We are working on that. And we realize that has put us in the position of not being held in high esteem by our colleagues who are used to a consultant telling them what to do. And it's not that simple in psychiatry to just tell you what to do. We have to explain to you why you are doing it, and we have to help you explain to the patient why it needs to be done. That's a little different from me going into consult on a kidney problem and saying that you'll adjust the medicines, you'll provide these fluids, and in 2 weeks we'll do a surgery and everything will be fine. Nothing in psychiatry is quite that simple.
Yeah, I jump in. I think that, as usual, my colleague is 100% right. The reality is it's in the minds of many persons in med school and other grad type programs to go into mental health care, psychologists and psychiatry in med school, and people are very often actively kind of pushed away from it. And the data are special when physicians are in practice in whatever specialty. If they decide to stop and choose a second career, they go into psychiatry, most commonly. So the reality is many of those persons probably thought about going to psychiatry initially, but were turned off because of many of the adverse concerns. You have stigma on your list of agenda issues today. I think reimbursement was an issue previously. But I think most importantly, just the idea of respect in the community, again, by doctors and also I think by the overall community. So starting early, getting this message out, I think is key. I'll just share with you, we had a mock interview for med students here just this weekend, and we did a debriefing afterwards. And of course, many are going to med school, but they begin to talk as well about special type issues. And I appreciated hearing that many of the students who were on the mock this Saturday understood that very often in psychiatry, we actually are a big tent group. We address a lot of issues in addition to the specialty concerns of psychiatry, also other concerns that I think are relevant, I think, for all persons, I think, in the healthcare arena, both professionally, I think, and also personally. So we probably should, I think, use that, I think, as a harbinger effectively moving forward. We should talk about it pretty actively. We should kind of get up very aggressively and kind of brag, if you will, on our career and our successes. I think very often persons need to hear there are individuals who do well and get off the meds or get back to functionality in life and move forward in many ways, rather than what we only tend to get now in the media is if there's a media person, if there's a celebrity, if they're finally willing to admit publicly that they're on antidepressants, kind of a real big thing. Very different than all the persons who I think are doing well practically in their overall functionality in their overall lives, many because of interventions psychiatrically and therapy and medication. So we've got some tools to use. I think we as a group should probably use them more assertively going forward.
In our organizations, I mean, my colleagues have mentioned a couple of things, and so, but there are some nuts and bolts because we know how medical education, graduate medical education is funded in this community and it's in this country, and it's funded out of the Medicare Trust Fund. And I can't tell you how many years I've gone up to the Hill and said, we need more funding for residency slots, right? And it's just not there. And so there's another opportunity whenever you are meeting with your elected officials to raise that issue. And so again, psychiatry is not the only shortage specialty, but clearly it's a significant shortage specialty. We need more slots. So that's a piece of it. That won't solve the problem because there is no one thing that solves this workforce problem, right? There are a lot of things. I love the pathway. We have to start early so that they are prepared throughout, so that when it comes time to go to medical school, they have the preparation that they need. So we have to think about that. And I'm going to even talk about the broader workforce. I think we need to think about using peers and train folks at all levels. There's a role for folks who are bachelor's trained. And I think we have to think about that. I graduated from West Virginia University, and I know not too far from Tennessee. But they have a program. I don't think it's unique, but they are training folks who maybe had another degree, I don't know, say sociology or some other degree, but realized they really wanted to go into mental health. Is there a certificate program, a training program that they can do at that level, at the sort of the bachelor's level, and then, master's prepared, of course, PhD, and then MD. So I think we're gonna have to really just totally rethink our whole mental health workforce, expand it. But of course, then it gets back to who's gonna pay for all of this. Now, again, the good news is that President Biden in his State of the Union address elevated mental health. We saw President Kennedy do that. We saw President Carter do that. Listen, and a lot of presidents have raised it, but I think to the level that President Biden. So now we'll need Congress to appropriate the funds for that. So, but again, states can, at state level, states can say, we want to fund 10 extra residency slots. Now, I know other colleagues on the call tonight will say, we need those too. And I think that's fine. You can fight for all of those, but we have to have this broader thinking about workforce diversity. And also, that being said, sometimes I worry that and I know that those of us who are informed don't make this leap, but sometimes people make this leap when we talk about the need for a more diverse workforce, physician workforce. Some people say, okay, good, then that absolves me of the responsibility of learning about and providing culturally competent, relevant care. And of course, that is cannot be further from the truth.
Yeah. And I'm so glad you mentioned that, Patrice, because if Dr. Washington, you talked about the 3%, and depending on whose numbers you look at, it's either 3 or 6%. And either way, there is hardly enough Black psychiatry workforce to address the needs of the Black population that is now willing to get treatment from a mental health professional, particularly a psychiatrist. And so we cannot back away from the fact that there are going to be people, and this is very controversial, there are going to be people who will receive treatment from therapists who are not Black. And those therapists need to be trained, as Patrice said, they need to be trained on working with patients of color from all walks of life, because we just don't have enough to take care of everybody. And I worry that we may be now setting up a scenario where if people are ready, they say, but I want to see somebody like you. And I can't manufacture people like me fast enough to give everybody the Black doctor they want. I know my primary care colleagues, I've had to wait for weeks to get an appointment with a Black doctor because I was committed to it, but I was able to wait. For many of our patients, the waiting period is when they drop away. And so we have to figure out the message to help them understand that if you have a well-trained therapist who is aware and skilled in cultural competency to begin with, and then we go on to structural competency and some other things. But as a starting point, someone who is not afraid to talk to you about race and racism and other things that may be a challenge, someone with whom you can have some kind of fit so that you at least raise these things and then you evolve that relationship. It may not be forever and it may not work, but if we're going to get people to agree to go into treatment and they've got to wait to see Dr. Harris, Dr. Bailey, or myself, or someone who looks like us, we're going to start pushing people away from treatment again. And we don't want that.
Making some good points. And I'd say on an optimistic note, we are seeing making some traction. First of all, to hear Alpha say that we may be at 6% is kind of warms my heart, because the truth is, so much of my career numbers have always been, you thought you're 1 and 2%. And then that was even a hit. Make some progress, but I'm gonna throw in a bit. I have to laugh. I do a lot of these on Thursdays with Alpha. I want my Alpha time, so I have my Alpha time today inadvertently. Was in the Alphas on the line, A5.
You got a lot of first fam on the line, Dr. Bailey. Many on this panel and in our audience as well.
Well, got Otis is on the line, and then he's my friend brother. But I mentioned that so. Love to Alpha, a mental health task force. I chair it, but we have a chair of the old healthcare program. Got him, Sterling. We were contemporaries going back 30 years. But I've just been so impressed. I mean, so it's by alphas and it's about alphas and it's for alphas. And we've got 12, 15 people, about half psychiatrists, half psychologists, Black males, talking to Alpha brothers every one Thursday night a month about mental health issues, I think, in our community. So even I've been surprised. It definitely seems to be, breaking down some barriers that historically existed. I've often said that even early in my career, you go to a health fair or a church and then everything but depression screening, cholesterol screening, blood pressure screening, whatever. And our churches even accept, in many regards, Black churches in our community in my hometown have some depression screening. And now we got alphas actually going on a social media bit on one night a month and talking about their mental health issues or concerns. I go a bit further by saying what I often will say in my experience is that, people say in many venues, Black men don't talk or don't go to the psychiatrist or whatever. And that has not been my life experience. I've been a human being my whole life. Somebody knocks on my door and wants to talk about it. And the exact same issues we discussed, I think, in a formal setting, it's just always been so informal because of the stigma. And somebody wants to kind of talk to you at Starbucks or on the phone or, behind the building, but not come to the office, sit in the waiting room and come in directly. So that's the next hurdle we have to address and cross, because otherwise Black men will get less quality health care than everybody else if inadvertently on our own, we block ourselves from going for professional care where it does exist. I'd also add that I think I'll throw up a perk in for Black male psychologists. I think that, I'm a psychiatrist and our numbers are very small, but in our vantage point, some of the issues, items that psychologists handle, I think very, very well also. And because there's this huge premium or adverse concern in our community to not take medication, or I'm not a proponent of that. I'm a proponent if you do decide that because of that, you're not going to go to see anybody at all, that's not a good thing. Go to a Black psychologist is the argument that I make very often to Black men, so that won't be the reason. I don't want any medication. They don't get mental health care at all. Huge issues that I think are very relevant. I love your point here on number 4. What can we do to increase the face of Black male professionals in mental health care? A huge issue that we must address. And as Alpha said correctly, I have to do it internally by getting the message out. Right. This is a fair place.
Yeah, so true. I definitely applaud the men of Alpha Phi Alpha and what they are doing to bring awareness to mental health. I have seen more so now that a lot of Black men are talking about going to therapy, going to counseling, and that's refreshing to see. There are so many people in our communities that could benefit from having a therapist that they see just to help talk and unpack. I will admit here on this line that I do have a therapist that I see regularly. We see people who are very high functioning and who are doing well, and we think that they don't have issues that they need to unpack and talk about. So really just to normalize that. And I have friends and colleagues that see therapists as well, and there's nothing wrong with that. I want to shift and start talking a little bit about Black men. I want to talk about Black women and how we access care. A lot of times when we talk about Black women, a lot of times we are kind of the ones that are pushing everybody else to get their care. But then often that is at the experience of ourselves, particularly those women who are mothers, who are caregivers, who are working. If they're doing all of those things, they're so busy taking care of other people that they don't necessarily take care of themselves. So what advice do you all give to these ladies in regards to their own mental health?
Well, I'd give that advice, I'd say to ladies, but all of us on this call, because, sometimes as caregivers and health professionals, we take care of everyone else but ourselves. And I'm guilty of that sometimes too. So it starts with self-care. And then I'll just, speak about Black women. And I've written and participated. I'm the chief health and medical editor of everydayhealth.com. It's an online publication, but we did a whole series of Black Health Facts. Where we did one on the burden of the strong Black woman, right? There's it's not a myth, it's true. Somebody says, no, it's not a myth, it's true. But there's this reputation of that, and then we have to hold, and we cannot admit weaknesses. And if we fall apart, I've heard somebody say that, who will take care of the family? And I always say, but if you are struggling, let's look at how the family is being taken care of. But in some instances, that's right. But I always say, we're going to support you, and we're going to support the family. We do have to make sure that people feel okay to not be okay. And I like the fact that Ron shared a story. I'm going to share two quick stories, but I think it's important for us. And I'm so glad you shared your story. During when Ahmaud Arbery here in Georgia was murdered. That was a day that that just tipped me over the edge. And I literally was not okay. But I was thinking, and I said, and I have privilege. I can work from home. I don't have to worry about my next meal. I have to worry about paying the mortgage. And so what I did that day again, and this was in some ways self-care, although I did take a moment. I turned off, cable news, and I did do some self-care things. But I did talk to my colleagues, leadership of the AMA, and I said, let's make sure we are checking on our frontline staff at the AMA, because this has been tough with George Floyd and for me, and so I'm not okay. And so I think just admitting that I am not okay is the thing. And I will share one more story about the burden sometimes in the microaggressions, and I'll try to make this very quick, but I was on my way to a meeting at the Greenbrier. I'm from West Virginia, at warts and all, it's my home state. And there's a wonderful resort there called the Greenbrier, and often I get invited back, and I fly into Roanoke, Virginia, and drive. And it's a beautiful drive. I miss the mountains and I enjoy it. But this particular night I had to take a late flight. So it's 10:30, it's dark, and I have to drive through some very rural areas. But I don't worry about that. And it's again, a fun drive, not so fun at night. But I noticed a police car ahead of me. And this police car was going about 20 miles an hour. Now it's 10:30 at night. I still have another hour and a half to go. And I'm on the program at 8 in the morning. But I will tell you, and so I thought, well, he's about to pull someone over. He'll pull someone over and I'll be able to at least go to the speed limit. And he didn't pull the person over. But here's what I had to think about that night. I said, what if I pass him and he pulls me over and I'm in the middle of nowhere? And it may take days or weeks, to find I mean, that's what I was thinking about. In the meantime, going 20 miles an hour because I'm too afraid to pass this police car, and I'm mad and I'm sad and I'm angry, and I'm traumatized by that. So I say that I think it's important for us to tell those stories, to share when we are not okay, not feel like we have to live up to reputations, just be who we are, give ourselves the grace and the space to not be okay.
Absolutely. That is so true. Let's talk a little bit about, because we have a lot of kind of comments in our chat feature. I am very encouraged because I see some medical students on the line who have interest in psychiatry. That's very encouraging.
Yeah.
I also see a lot of other kind of community-based resources. Someone mentioned in the chat about a project called the Confess Project, where barbers are trained to provide mental health services to their clients, and wanted to get you all's opinions of that type of service that would be in our communities. Any comments there?
There've been more than one of those in the past, and this newer one, I think, along that line, that African men particularly have historically spent a lot of time in the barbershop. Patricia, from the personal story, incredible story you share, Patricia. I think it sounds very authentic, and unfortunately, all of us probably share with that fear that can happen in that type of situation. I'm somebody that kind of grew up in a life going to a barbershop. My father on a Saturday and spending at least an hour, sometimes more, every Saturday. This time that one now doesn't think that you actually have. But it probably was a lot more about the socialization and sharing ideas in a safe environment for Black men, as much as getting that haircut. So the personal rights about it, I think that the key themes for me that resonate is people have to find a safe space, and it's harder for Black men space to talk about what really bothers them and how they feel. Either A, because access doesn't exist, or B, you'll be made fun of or thought differently because of stigma. Huge issues, I think, but you can say those things in that environment in a bit of a jocular way. People kind of laugh about some things, but they're laughing with you and not at you. Huge issues, I think, though, to find ways to tell our young men and middle-aged men that it's fair and reasonable to be supported, and find a safe place to discuss our vulnerabilities and areas I think that we feel bad about ourselves.
Yeah, that's very important. Also in the comments was talking about children. I feel like our children have really suffered a lot during this pandemic, and then having so many other things to think about that we didn't necessarily have to think about 20 years ago. Let's talk about the role of social media in the mental health and well-being of our children. Do you guys care to comment on that at all? I think it's so much to unpack with that topic.
Let me say one thing about the barbershop, and that I think we need to use our community-based assets, right? And it will be different in every community. But we also have to make sure that those community-based assets not only get the support they need, but also get connected, right? Because when it goes beyond what our barber or hairstylist feels comfortable discussing, we need to make sure that there's a next step. And I think there's a huge gap in that. So clearly, we should be using our community resources and connecting and just winding all of this together. I also saw something, and I just right before we started, I had a couple of I don't know if these are memes. I'm old, so I don't know the right terms for some of these social media terms, but they show what Melissa Harris Perry called and actually I don't know how many of you were at NMA in Hawaii. The women physicians in the room, and Melissa Harris Perry spoke at the luncheon, and she had some photos of what she called Black girl skepticism and that look. So right before we started tonight, I was sent a couple of things of that look, right? And it was Felicia Rashad as as Mom Huxtable. It was our Vice President Harris, And it was Ketanji Brown Jackson today, of course, having the grace. But also there was one photo where she had that look, and everybody knows what that look is, because your mother, your sister, your grandmother had that look. Your wife, your spouse, your partner has had that look. So, and that is, it's very frustrating and it's very angering, and we laugh about it, but it is, I mean, it just adds to, and if you want to use the word, the trauma of, again, being overqualified and still being subject to nonsense. Fair questions, hard questions, yes, but the nonsense, and that's a community frustration. Social media is, again, you know, there's promise and peril there, but unfortunately we have seen, you know, the data regarding increased anxiety. And listen, everyone's lives are perfect on social media, right? You have the perfect relationship, the perfect house, the perfect car. If I turn my camera around, you'd see several shoes on my floor, but right now you just see this perfect little clean background here. So social media, but as adults, we can sort of manage, and we know nobody's life is perfect. But I think adolescents, again, live in an age of anxiety that I said, think about our adolescents and young adults, again, have to participate in active shooter drills in school. And again, social media and bullying, and, you know, the perfect lives, and to be thin, and all of these things. So certainly we need to, social media is having a negative impact. Now, on the other hand, social media has been a way that all of us have been able to connect. We're connecting tonight and having this great conversation virtually, the broader definition of social media, but clearly there are issues. And I think this is where society has to act. You know, free speech, I get all that, but we really need, this is my personal opinion here, some regulation around this. And then, of course, parents and caregivers need to regulate this as well. There's responsibility all around as to, you know, phones and computers in rooms. And I'm not going to preach, and people can raise their children how they see fit, but just appreciate the context and do what you need to do to make sure your children have balance in their lives. As a child psychiatrist, that's my advice tonight.
Thanks so much for that. Yeah, you know, there is so much that we can talk about with this conversation. I mean, we've been here on this call for a little bit over an hour. I know last time we were having to wrap it up very quickly. So I do want to take just kind of the last about 12 minutes or so and just kind of give, for you all to just give your overall assessment of mental health in the Black community, and maybe 2 or 3 things that we can do as healthcare professionals to improve mental health in our communities. And whoever would like to go first, please do.
So go ahead, Ron.
I was going.
Okay, I'll go first then. What can we do to improve mental health in the Black community? We can continue to talk openly about the fact that it exists, that we are not somehow removed or immune to mental illness. It is not the white man's disease. It is something that has a history that is tied to the racism in this country, but it is also tied to those things that happen in life that are a part of living. Sometimes it's a situational issue. Sometimes we are predetermined, if you will, with certain characteristics and other things that manifest. And we can't ignore any of the reasons why, and we shouldn't ignore the fact that they exist and occur. And again, I will say that effective treatment is available. This notion that I don't want to take medicine may sound like a wise move, but the suffering and pain that goes along with some mental illness, and certainly with serious mental illness, can be alleviated with medication. And in the right hands, given the right kinds of treatment, people can live much better quality of life, can have a much better quality of life and really enjoy life. And everybody deserves that. The other thing I think we can do to improve health, mental health in the Black community is to promote what Patrice said earlier. There is no health without mental health. We have got to recognize that our brain and bodies are not disconnected from each other. And what happens in one can impact the other. And that as physicians, as healers, we have got to ring that bell, sing that song, ride that train, whatever analogy works for you. We have got to be out there leading the charge that Black people's mental health matters.
So I would say a couple of things, and it's always hard to follow Alpha, but I would say let's mind our own biases, slightly connected, watch our words and our language. Sometimes, again, all of us, including me, we get a little lazy and we use slang and jargon, but we should be careful. Words do matter, and addicts and junkies, and we should just monitor those words. Probably we don't use those words in our professional settings. We should also watch using those words in our personal settings, because you never know who's listening. Mm-hmm. And as physicians, people have heard me say that I wanted to be a physician because of Marcus Welby. Growing up in West Virginia, didn't have any. But what I saw in Marcus Welby as a physician, he had a platform and people listen. And so I realized over the years, physicians maybe inappropriately were put up on a pedestal, but we do have a platform and people listen to us. People trust us. People still trust their doctors and nurses. And so we have a platform. So mind our language. Make sure we don't use words, even in jargon, like something is schizophrenic. I've heard that. So that's about the language. Make sure that perhaps in your offices or in your health systems, that there is material that supports seeking help. And those of you who are leading, whether you lead a large institution or a small institution, make sure your carriers, if you provide insurance, pay mental health in the same way they pay for other med-surg diseases. So I would say those are two things. So be an advocate from payment on down to help seeking, and watch our language.
Good. Well, I want to thank Dr. Washington and the entire group at Bluff City for all of us. Myself, I enjoyed this group very, very much. Two outstanding panelists to share the discussion with. I'll leave with a couple of things as well. I know we plan on talking about suicide tonight, but so much discussion. We spent a lot of time on it, but the one point I want to make sure we leave the audience with is this new data that has been pretty much supported throughout my career, that before somebody suicides, they tell somebody. And very often they tell somebody who's about one in four persons within the last month. They've talked about it. And very often we talk about it with someone who's not a mental health professional. Maybe they're primary care or psychiatrist. Maybe they're mental health professionals, not a psychiatrist, or maybe they're the primary care doctor. So we all should have our index of suspicion on high in general, but especially during these times that are post-pandemic and under the kind of stressors that I think are problematic for many. I mean, we're in war now in our world for the first time in probably the better part of 6 or 7 decades. I mean, real war, if you will, that's probably not likely to be negotiated its way out of. I'd also make the argument, I start off talking a bit about violence and gun violence. I don't think we can really talk about it enough. I think it adversely affects our community, and I think we have to address it at every possible way. One thing I'll say now that I didn't say earlier is I think we probably should push, and Patrice mentioned being involved in advocacy, our politicians to enact laws that would make our community safer. And so the biggest ones to me are that we can make guns only work if somebody buys it and gets programmed. But that's a data piece that I think very often is not discussed a lot. As I've learned, and I've just been shocked that it's not implemented, but it's also not implemented because there's a gun lobby that's making, probably $3 billion a year off the bartering, I think, of young persons' lives, especially young African Americans' lives. I think, unfortunately, very metaphorically similar to 4 centuries ago in the slave trade. the lives of young Black males when they are at high risk. We don't see a government that actually changes. I find that objectionable, and we have to speak, I think, out against it loudly and actively. And really, the final point I'll make is I kind of started tonight with issues about New Orleans, and I'll end with New Orleans. And I think New Orleans is a metaphor for many of our urban city communities. I think New Orleans and Memphis may be sister cities, if you will, very similar in so many ways. Our young people are crying out for us, asking, I think, for our help. Not only do our med students want to look at us as, I think, mentors and role models, I think the young persons who don't know us, who maybe have less resources and maybe having great difficulty in society, when they recognize that we've had some success in the way we engage and interact with them as best we can, I think it's helpful. I want to believe it's helpful. I have to believe that it's helpful. And I think those are issues that we have to kind of take home and be positive about and try to use those concerns, I think, to really advance our communities. Again, thank you very much for having me with these two people that we admire so much.
Thanks so much, you guys, just for those final comments. So many rich comments that you guys made. I mean, we talked a little bit about the social responsibility that we have as individuals in the community, not only healthcare professionals, but other people of influence within our communities, and the importance of talking about mental health in our communities, the need to seek care, and the fact that it's okay to seek care. We talked about as healthcare professionals that we need to have a high index of suspicion that something may be going on with our patients. And we need to ask those inquisitive questions to try to figure out if there's some deeper issues that are lying in the background that we might not see. The patient may come in saying that they have, chest pain or headache, and that really could be the indicator that there's something more that's going on with those individuals. I think Dr. Stewart mentioned mental health and saying some parts of mental health may have a genetic component, but sometimes it's environmental, situational. So it's important that we talk about that as well. And then Dr. Harris mentioned checking our own biases. Just as healthcare professionals, we know that if we are living in this community, as many of us have our entire lives, that we do have some inherent biases. And it's important that as physicians of color, as people who are not of color, that we examine those and understand how they might impact the care that we provide to our patient population, and understand that that might be harmful. And then also recognizing that it's very important for us as healthcare professionals to be providing care in a trauma-informed way. We have some people in our chat and also on our social media where we're sharing this video that provided some resources that would assess and give you background and to assist you with providing trauma-informed care. And that's very, very important. And I think Dr. Stewart really talked about that a great deal when we talk about, our workforce challenges. We don't have a lot of mental health workforce of color. And so it's important that our majority colleagues do take time to understand the unique dynamics of communities of color and situations that impact them, and how they can provide care in a more effective way. And then also one thing that I think is really, really important that we don't do enough of is reaching out and engaging our elected officials and encouraging them to fund programs that will help our communities, whether it's mental health, which we're talking about tonight, whether it's medical care, whether it's increasing residency spots so that we can have a larger medical workforce. All of those things are extremely important as we continue to work and push forward with a lot of the initiatives that we're doing in our communities. So thanks to everyone for joining us tonight. I always have an amazing time with Dr. Bailey, Dr. Harris, and Dr. Stewart. Last time y'all called me an honorary psychiatrist. I don't think that I really deserve that honorary status at all, because I'm definitely not a psychiatrist. But I understand, and I always enjoy being able to share the same virtual stage with each of you all. And so we've had a really great attendance tonight. Again, this video, we will upload it to our YouTube page, and it will be on our Bluff City Medical Society website. I do have one last little screen that I'd like to share here for you guys, just so you can see our last screen here. So thank you all for joining us tonight. I'm going to ask for you all to follow us, please, on social media. We're at Bluff City Med. That's on Facebook, Instagram, and Twitter, and also to check out our website at bluffcitymedicalsociety.org. So grateful for you all for coming tonight to this virtual space. We're having lots of great comments in our chat. Everybody's so grateful that you all were able to join us tonight. And thanks everyone, and have a good evening.
Thank you, Dr. Washington.
Good night. Thank you, Dr. Washington.
Good night, everybody.
Good night.
Got it.